Good morning. Welcome back to the OHSU Effect Inside Health and Science. I'm Lacey Evans. Our next topic is a little uncomfortable to discuss, but it's important. We're talking about colorectal problems, including cancer and inflammatory bowel disease. With me now on KXL is Dr. Liana Tsikitis, a colorectal surgeon. Good morning.
Good morning.
Okay, what is irritable bowel syndrome and the difference between inflammatory bowel disease? I think we should start there.
Very good. Irritable bowel syndrome is an alternating symptomatology of diarrhea, constipation, bloatness. A lot of patients feel pretty sick. They come with a chief complaint to their medical doctors of not tolerating diet well and having changes in bowel habits. But it's not really a proven histological entity, meaning that when I take biopsies of the colon, I don't find a disease. Inflammatory bowel disease, on the other hand, it is histologically proven, and it involves ulcerative colitis and Crohn's disease. So it's an umbrella of two entities, and it can be extremely serious. It does have a very different symptomatology, and some patients have it significantly severe or much milder forms we see as well.
And then that's what you deal with.
Exactly.
How many people are affected?
In the United States, I would say about 600,000 people with Crohn's disease and probably about double that number of ulcerative colitis. Crohn's disease and ulcerative colitis are both entities that gastroenterologists as well deal with mainly because we have medical management. But there is the point that we reach at certain times where surgeons are needed, particularly in my specialty.
So what are the symptoms and when is the time that people need to seek treatment?
Okay. Well, the symptoms, it's both entities tend to be bimodal. And what I mean by that, usually in teenager years. The significance, actually, the biggest complaint that comes is the diarrhea with blood. Anytime you pass blood is not normal. You need to, work it out further. So they go to their PCP and significant abdominal pain. So it starts early. Both diseases start early, like in the teen years. And then we have a quiescent period in certain patients, and then this starts again like in 60s and 70s. That's what I mean by bimodal disease. Now, when do they seek treatment? I think as soon as somebody does not feel well, a teenager that does not feel well, they start having bloody bowel movements or abdominal pain, it needs to be worked up. So I think with the very first symptom, when something is not normal, it should be sought after,
Yeah, I'm surprised to hear you say teenagers, because when we think of colorectal problems, we think of older people.
Yeah. No, unfortunately, Crohn's disease and UC are in young people, like 15 and 14 is when they usually first get diagnosed. And unfortunately, it's a diagnosis for life. Crohn's disease, unfortunately, we cannot really cure, but we can prevent it from happening in more severe forms. We can control it and have them in remission. With ulcerative colitis, surgery can cure them, but it means a life-altering, operation for them. So, and it gets a little bit more complicated. But definitely with UC, in one of the two forms, the UC is the one that I could say, as a surgeon, I could offer a cure. Where in Crohn's disease, unfortunately, I can control it, I can make the symptoms better, but I cannot cure it.
Yeah, I wanted to ask you about prevention. So is there anything people can do?
There is really nothing that we know of. We know that it runs in families. So if there's a family history of Crohn's disease or ulcerative colitis, there is a higher likelihood for a member of that family to develop it. We know that it's genetic associated when it comes to Crohn's disease again. There is nothing really to do to prevent it, but I think awareness, being aware that these are maybe the initial symptoms and starting treatment early, it may make the symptoms to be much less severe and provide a better quality of life. So it's important to be in the back mind of patients that have family history of those entities.
Well, let's talk more about quality of life, because just as a person who doesn't have this and isn't affected by this, I can imagine that a person would be miserable. Is that the case?
Absolutely. And apart from the pain and staying away from work, people with significant blood loss, that they need transfusions, they get hospitalized. It can get to the point that it can be fatal. And this is when emergent surgery happens. So yes, it's definitely life-altering. But again, I want to be optimistic in my message that if you're aware of it, if you are close to your gastroenterologist, you have a good rapport with your doctors, there's definitely treatments that can make it milder. And if it doesn't happen to be, then surgery will be definitely indicated and can help a lot. Bring back, as I tell my patients, I can give you your life back, after the surgery. So that's extremely important.
Where can people go for more information about IBD? Is there a website?
So there's a website. There's a gastroenterology website in OHSU. And also we're working on our surgical website, actually, currently. There's going to be a site also in colorectal surgery and what a colorectal surgeon can offer for IBD patients.
And we'll have links to those on our website, the OHSUeffect.org. Okay, I want to move on because you also deal with a lot of complex colorectal problems like colon cancer. So what is the most common diagnosis there, and what is the treatment?
So colon cancer, much more frequent. We have about a 6% chance in average population to get colon cancer, so it's pretty common. It's the third most common lethal disease. Cancer-related deaths. It's related to colon cancer. So definitely what I want to pass as a message is at age 50, when there's no family history, everybody needs to get a colonoscopy. I don't care how well they feel, because unfortunately the symptoms of colon cancer is none, and I cannot emphasize that enough. So colonoscopy, it's a disease, it's a cancer that 90% I can prevent it by doing the preventive measures such as colonoscopy, flexible sigmoidoscopy. Literally, listen to your doctor. When there is a family history of colon cancer, then definitely they need to start younger. I recommend 10 years. We always recommend 10 years earlier than the family member was diagnosed. So if somebody was diagnosed at 45, we start at 35. And I know at 35 you feel invincible, but unfortunately it's a bad disease. The good news is it can be completely cured if it's caught early.
And is there any clinical research going on that's going to have an impact on these people?
Definitely, there's a lot of research going on in chemotherapy drugs for colon cancer. As a surgeon, I don't even want to think of later on the chemotherapy, because that means that the cat is out of the bag, as I say, and it's pretty advanced. But there's a lot of research actually understanding the genetics behind it and being able even to predict and prognosticate better for colon cancer. So it's going to make us change the way we think of staging, we think of treatment. So there's a lot of great research actually going on in OHSU right now.
And you see patients at the OHSU Digestive Health Center. And if people want to make an appointment with you or any of your colleagues, they can call 503-494-8311. Just want to put that out there in case people need some help.
Yes, absolutely.
All right, that's Dr. Liana Tsikitis, a colorectal surgeon up at OHSU. Thank you so much.
Thank you.